Start.
Good morning, Madam Chairperson, my fellow pathology fellow colleagues, and all the participants, and ladies and gentlemen. It is greatly honored me to chair these sessions on the pathology papers. There will be altogether 6 papers to be presented. Since this oral presentation will be also 2 credits for the paper contest, all the presenters are requested to stick your allowed time. Let's see, 10 minutes for presentations and 5 minutes for discussion. The discussion will be followed only after all the presentations are completed. All the 6 papers are finished, presented. And the question and answer section will be followed after the paper presentations. And the participants who will shoot the question are also I'd like to request to make your suggestions or comments or questions in the chat box, please. Okay, for this, I will start this session with the first speaker. Okay.
Dr. Scientist တို့ဆိုပါဆရာကြီးဟုတ်ကဲ့ဆရာကြီးနဲ့ဆရာမကြီးများအားလုံးနဲ့ audience များအားလုံးပါမင်္ဂလာပါခင်ဗျာကျွန်တော်ခေါင်းစဉ်ကတော့ determination of ABTT plasma fibrinogen level and hemoglobin A1C level in type 2 diabetes mellitus မှာဖြစ်ပါတယ်နားလေးတော့ဆရာ next သွားလို့မရဘူး Okay, so introduction: diabetes mellitus is a clinical syndrome characterized by hyperglycemia due to the validity of isolated insulin deficiency. Diabetes mellitus has been defined by RBS greater than or equal to 7 millimole per liter and RBS greater than or equal to 11.1 millimole per liter. Globally, it is estimated 366 million people suffer from diabetes for a prevalence of the worldwide prevalence of the diabetes mellitus has been rising dramatically over the past 2 decades and will continue to increase in the near future. Although the both prevalence of the type 1 type 2 diabetes mellitus increases and the type 2 diabetes is expected to rise more rapidly in future because of increasing obesity, sedentary lifestyle, and sedentary diet, increasing urbanization and economic development. In Myanmar, diabetes mellitus are also in the rising trend. According to the YGH data, diabetes mellitus increased from the 200 cases per month 2011 to 250 cases per month in 2015. Most are over 40 years old and type 2 diabetes account for 95%, and because so that the diabetes mellitus has been an alarming situation in our country. Two studies are epidemiological fibrinogen test paper. Epidemiological fibrinogen tests are the potentially be used as screening test for the to assess the complication rates in type 2 diabetes mellitus. Shortened ABDD and elevated fibrinogen level as a hemodynamic marker of hyperglycemia in the shortened ABDD may reflect the hyperglycemic state associated with the increased metabolic rates and about the cardiovascular events. Shortened ABDD may reflect the program imbalance with increased levels of coagulation factors. So ABDD can be used to assess the risks of thromboembolic complication in diabetes mellitus. Recent document also documented the correlation of high fibrinogen levels in diabetic control patients, poor control patients with increased risk of thrombotic complications. The UKPDS also stated that hemoglobin A1C and development of the long-term complication of diabetic mellitus are positively correlated. The higher the hemoglobin A1C value, the more increasing the occurrence of various micro and macrovascular complications. This study would have the clinician to some extent in the management of and prevention of the cardiovascular complication in those with high risk of the diabetic complication. This study was to take out the associate to show the association between ဒီကတော့သုံးခု association ရှာပါတယ်ခင်ဗျာ ABTT and plasma family level hemoglobin A1C level in development of to assess the atherosclerotic complications among the type 2 diabetic mellitus ဒါမှဒီ method ဖြစ်ပါတယ်ဒါမှ option 2 plus calculation analyzer တော့ for ABTT နဲ့ plasma family တိုင်းဖို့အတွက်သုံးပါတယ်ဒါမှ TCA 2000 plus analyzer uses the latest accumulation method ကိုသုံးပြီးတော့ hemoglobin A1C တိုင်းဖို့အတွက်သုံးပါတယ် blood sample juice တွေသုံးပါတယ် citrate juice for ABTT နဲ့ fibrinogen တိုင်းဖို့အတွက်သုံးပါတယ် EDTA juice ကတော့ hemoglobin A1C တိုင်းဖို့အတွက်သုံးပါတယ် ventilator spray သုံးပါတယ် disposable syringe and needle micropipette တွေပါပါတယ်ဒါကတော့ reagent for the ABTT ပါ reagent for the ABTT မှာ 20 kilo ABTT HS ပါပါတယ် calcium chloride ပါပါတယ် reagent for the plasma fibrinogen မှာတော့ lyophilized calcium thrombin on the bovine origin and bionepapa ပါပါတယ် hemoglobin A1C အတွက်ကတော့သူရဲ့ mouse monoclonal antibody absorbed on the latest particle agglutinated and buffer solution ပါပါတယ် This study was a cross-sectional discrete study ဖြစ်ပါတယ် This study was carried out the study from the 2015 August 2016 December လုပ်ပါတယ် 60 cases of clinically diagnosed type 2 diabetic patients with criteria were but to the study after explaining the study and taking its full concept about the 4 measure ယူပါတယ်2 measure တော့ citrate 2တဲ့ထည့်ပါတယ် to test the plasma ABTT and fibrinogen level တိုင်းဖို့အတွက်ပါ remaining 2 measure EDTA ယူတဲ့ထည့်ပါတယ် for hemoglobin A1C တိုင်းဖို့အတွက်သုံးပါတယ် blood sample hematology and chemical pathology sections of the YGH ကိုပို့ပြီးတော့ analyze နဲ့ test လုပ်ပါတယ်ဒီကတော့ဒီကျွန်တော်ရဲ့ result finding တွေဖြစ်ပါတယ် mean age ကတော့ 54.37 year ရပါတယ် median age က 56 year ပါ40 less than 40 years age တွေကတော့ 11.7% 41 to 50 year 21.7 and 51 to 60 year 40% ပါပါတယ် 61 to 70 21.7% and 71 to 80 years က 5% ပါပါတယ် family history ကတော့ 50% ရှိတာတွေ့ရပါတယ် complication ကတော့ 53.3% ရှိတာတွေ့ရပါတယ် among the 60 case မှာ ABTT normal ထွက်တာ 76.7% short term ကတော့ 21.7% နဲ့ prolong ကတော့ 1.7% ထွက်ပါတယ် fibrinogen အနေနဲ့ကတော့ among the 60 case မှာ normal ကတော့ 73.3% ထွက်ပါတယ် increase ကတော့ 21.7% ရပါတယ် decrease fibrinogen patient တွေကတော့ 5% ပါတာတွေ့ရပါတယ် glycemic control အနေနဲ့ဆိုရင်တော့ good glycemic control patient တွေက 45% ပါတာတွေ့ရပြီးတော့ moderate အနေနဲ့ 23.3% ပါပါတယ် poor အနေနဲ့ 31.7% ပါပါတယ်ဒီကတော့အဓိက association ဖြစ်တဲ့ glycemic control နဲ့ ABTT ရဲ့ association ကိုပြရတာဖြစ်ပါတယ် good glycemic control patient တွေကိုမှာ 27 patient တွေမှာ ABTT normal 81.5% patient ပါပြီးတော့ short term ကတော့ 14.8% prolong ကတော့ 3.7% ပါပါတယ် moderate glycemic control patient တွေ14ယောက်ထဲမှာ normal 78.6% ပါပါတယ် short term 21.4% ပါပါတယ် prolong 0% ပါ poor glycemic control 19 patient တွေမှာ normal ABTT 68.4% ပါပါတယ် short term ABTT 1.6% တွေ့ရပါတယ် prolong ABTT 0% ပါ association ဖြစ်တဲ့ binding chi square test နဲ့တွေ့တဲ့အခါမှာ there was no association between the ABTT and hemoglobin A1C level နဲ့ ကြားမှာ association မထွက်တာတွေ့ရပါတယ် p value က more than 0.05 ထွက်ပါတယ်ဒီကတော့ glycemic control နဲ့ fibrinogen association ကိုပြရတာပါ glycemic control good patient တွေထဲမှာ normal fibrinogen patient တွေက 77.8% ပါပါတယ် increase က 18.5% decrease က 3.7% ပါ moderate glycemic control group ထဲမှာ normal fibrinogen 71.4% ပါပါတယ် increase fibrinogen 28.6% နဲ့ decrease က 0% ပါ poor glycemic control patient တွေထဲမှာ normal fibrinogen 68.4% increase က 21.1% နဲ့ decrease က 10.5% ဖြစ်ပါတယ်သူလည်း biology နဲ့ chi square test နဲ့တွေ့တဲ့အခါမှာ there was no association between fibrinogen and hemoglobin A1C level ဖြစ်ပါတယ် discussion မှာ age group ကိုကြည့်တဲ့အခါမှာဒီကျွန်တော်ရဲ့ study မှာတော့ between the 40 to 80 year age ပါပါတယ် mean age က 44.37 ပါ majority age က 51 to 60 year ဖြစ်ပြီးတော့ study population က 40% ပါပါတယ် young age က 32 year old age က 80 year ပါ this finding were not so different from the study ရဲ့ ခြင်းမူရပါဒီသူရဲ့ study မှာတော့ main age က 55.19 year ဖြစ်ပြီးတော့ majority က 50 to 59 year age group ပါပြီးတော့ 39.5% ပါပါတယ် diabetic history နဲ့တော့ဒီ study မှာတော့ 30% history ရှိပါတယ် this finding were not so different from the study ရဲ့ ခြင်းမူရပါသူရဲ့ study မှာတော့ 39.5% from history ရှိပါတယ် complication မှာတော့ဒီ study မှာတော့ 53.3% complication of diabetic history ရှိပါတယ်this finding were not so different from the study ရဲ့ ခြင်းမူရပါသူရဲ့ study မှာတော့ 48.8% complication ရှိပါတယ် ABTT အနေနဲ့ minimum 18.1 second ပါ maximum 49.5 second အတွက် main ABTT က 24.74 second and shortened ABTT က 21.7% patient မှာတွေ့ရပါတယ် this finding were not so different from the study of George Way သူရဲ့ study မှာတော့ main ABTT က 33.24 second and shortened ABTT က 31% patient မှာတွေ့ရပါတယ် Fibrinogen minimum 120.3 milligram per deciliter, maximum 460, and mean fibrinogen 304.9 milligram per deciliter. Increased fibrinogen level 21.7%. This finding were not so different from the study of Joshua. Mean fibrinogen level 385 plus or minus milligram per deciliter. Increased fibrinogen 42%. In this study, mean plasma hemoglobin A1C level 10.6%. This finding were not so different from the study of J2 and student Namiba. J2 study model, main hemoglobin A1C level 7.4%. Student Namiba study main hemoglobin A1C level 7.5%. Yaro Joshua Mabioga Dubabe, ABD Glycemic Control Association. So Mabioga Dubabe, by using the kind square test, there was no association with Fabau. P value was 0.57 Fabare. This finding was consistent with the study of Apasi at over 2 study model, and no significant association between the ABD and the tomorrow P value was 0.6 for that 3 hours. Yaroshima Bioga Glycemic Control and Fabinogen Association of Yaraba. By using the kind square test network, there was no significant association between the Fabinogen level and hemoglobin. P value was 0.64 Fabare. This finding was consistent with the study of Apasi at all. 2 study model, P value was 0.13 Fabino association of Java. This area had a relatively small sample size concerning the ABDD plasma fibrinogen level and hemoglobin A1C level. But the below and the type would have been to determine association parameter. There was no significant association between ABDD plasma fibrinogen level and hemoglobin A1C association. That further stay into the additional more collinear parameter last sample size in a tabula, a cell of not expert to remote communication you, a cell of conclusion recommendation diabetes are one of the most common chronic communicable disease. Diabetes high risk of the autonomic advancing. 80% of patients have 75% cardiovascular complication. If hemoglobin A1C level high, actually, the more increase in the occurrence of various micro and macrovascular complication in the eye. The shortened ability to improve ambulance if the population levels is double. But I am ability to assess the risk of the thromboembolic communication as a logo there. Fibrinogen level poor glycemic control patient high fit increased risk of the thromboembolic communication in the eye. These days, the tongue ABDD plasma fibrinogen level association with Shara. Hemoglobin you also told to Fabio cook and moderate poor association. There was no significantly associated about short time ABDD and increased fibrinogen level with the poor glycemic control. P value was 0.05. Although the ABDD and fibrinogen tests are readily in available, these are very limited for evaluating the term only risk in the patient. Long followers study research to find a between the patient and other cognitive fatality hyperlipidemia in a shabu to suggest the right. Darokona do a second form of primary ocean tubeless analyzer, fibrinogen reagent, ABDD reagent, Daro, TC 2000 flags analyzer say, hemoglobin A1C practice by Yaro, a reference to the body. I don't know the magna.
Thank you.
Okay, was I do Wagner?
Second paper, please.
Good morning, Honorable Chairperson, Professor, and all my senior colleagues. I'm Dr. Puzeni, Junior Pathologist for Yangon Specialty Hospital. And today I would like to present about immunoexpression of matrix metalloproteinase 9 in endometrial adenocarcinoma. Endometrial cancer has become the common malignant tumor of female genital tract, but the incidence varies in different countries. It is the 6th most common cancer worldwide for female and 17th most common cancer overall. According to the data registry from Gynecological Oncology Unit of Yangon Central Women's Hospital, the number of new endometrial cancer cases were as follows, showing increasing trend of disease incidence. The poor prognostic factor for this disease include cancer cell invasion through the myometrium and then to nearby lymph node, and metastatic spread require the interaction between tumor cell and component of extracellular matrix. So degradation of basement membrane and extracellular matrix is an essential step for cancer cell invasion, and this step require the action of enzyme proteinase. Matrix metalloproteinase, also known as matrixin, are independent endoproteinases which are involved in degradation of ECM. Among them, MMP9 is able to degrade type 4 collagen, which is the main component of basement membrane. So it was found to be overexpressed in high-grade endometrial carcinoma by degrading basement membrane and invading through the myometrium, so they play an important role in tumor growth, invasion, and metastasis. It was also reported that positive and benign staining in high-grade tumor were associated with unfavorable prognosis. So this study attempts to find out the correlation between MMP9 immunoexpression and different histology type and grade of endometrial cancer by using immunohistochemical method. And I hope the finding of the study will give valuable information about assessment of tumor aggressiveness, disease prognosis, and early intervention with MMP inhibitor, which may improve survival and quality of life in disease management. It was a cross-sectional discrete study design, and total of 41 cases with endometrial carcinoma admitted to CWH were included. First of all, the following were obtained after explaining the research purpose, procedure, and benefit of the study. And histology type and grade classification was done on H&E stain tissue section according to the WHO classification. And then the representative profile was flowed with further process for IC staining with MMP9 monoclonal antibody by using PET method. For interpretation of MMP9 immunoexpression, bronchial cytoplasmic staining indicate positive immunoreactivity of MMP9, and both positive and negative control were run in parallel with steady cases, and we use a known case of MMP9 positive breast carcinoma as positive control, and for negative control, we omit the step of primary antibody application during the staining. And score 0 to 3 were given for staining intensity, and score 1 to 4 for percent of positive cell stain in 500 tumor stain. Final score or immunoreactive score was obtained by multiplying staining intensity and percent of positive cell, ranging from score 0 to 12, and IRS score 0 to 3 was considered as negative immunoexpression and 4 to 12 as positive immunoexpression. Data were analyzed and evaluated with regard to inner objective by using SPSS partition system, and the association between MMP9 expression and histology type and grade of endometrial carcinoma were tested using chi-square test, and p-value of less than 0.05 was considered to be significant. In this study, the most affected age group were 40 to 60 years of age, followed by over 60 years of age, and only 1% was under 40 years of age. And postmenopausal women were more affected than premenopausal women. And out of 41 cases, 38 cases were type 1 endometrial carcinoma and 3 cases were type 2 non-endometrial carcinoma. There were 8 cases of grade 1, 24 cases of grade 2, and 9 cases of grade 3 adenocarcinoma involved. And 18 cases show less than half of myometrial invasion, and 23 cases show more than half of myometrial invasion. Regarding IRS scope, MMP9 immunoexpression was negative in 6 cases and positive in 35 out of 41 cases, accounting 85.4%. This table shows association between MMP9 immunoexpression and different histology type, grade, and myometrial invasion of endometrial carcinoma. And we found that there was statistically significant association between MMP9 immunoexpression and histology grade with p-value 0.04, but not with histology type and myometrial invasion, p-value 0.614 and 0.377 respectively. These are figures showing positive MMP9 immunoexpression in grade 1 endometrial and grade 2 endometrial carcinoma. And these figures are showing strong MMP9 immunoexpression in grade 3 endometrial carcinoma and grade 3 serous adenocarcinoma. Endometrial cancer is common gynecological malignancy and also the common cause of cancer death from female cancer. And its incidence has been increasing over the past decade, especially in developing countries because of urbanization and lifestyle changes. And it typically affects elder women, but it can occur in any age group. In this study, the highest incidence was found in the age range of 40 to 60 years. The youngest age was 36 years and oldest being 76 years. Majority are postmenopausal women, counting 68.3%. In the present study, positive MMP9 immunoexpression was revealed in 85.4% of cases, and result was similar to other study of Karahan et al. And Vijay et al., who found MMP9 positive immunoexpression of 90.5% and 71.1% in their study, respectively. But it was different with Aglan et al., who found only 53% of MMP9 immunoexpression in their study. So the different results may be due to different reagents used in IC staining and difference between specimens. Among 41 cases, 84.2% saw type 1 and 100% saw type 2 carcinoma show positive MMP9 expression, but it was not statistically significant. that MMP9 immunoexpression was seen in all cases of type 2 endometrial and endometrial carcinoma, which is associated with poor prognosis, high grade, and aggressiveness. And in this study, positive MMP9 immunoexpression was found in 50% of grade 1, 91.7% of grade 2, and 100% of grade 3, with statistically significant association of p-value 0.004. And out of 8 cases of grade 1 adenocarcinoma, the majority show weak staining intensity, and only 2 cases show strong staining intensity, which are associated with more than half of myometrial invasion. In grade 2 and grade 3 adenocarcinoma, most tumors stain moderate to strong staining intensity. That means MMP9 immunoexpression was significantly increased in high-grade than low-grade tumor, which may be due to presence of interbasement membrane in low-grade tumor. The results are similar to other studies of Eglin et al. And Denizer et al., who found overexpression of MMP9 was higher in grade 3 adenocarcinoma than low-grade tumor. That it is inconsistent with the study of Karahan et al., who found MMP9 was overexpressed in grade 1 and no association between these two. So the discrepancy between the study may be due to difference in IC staining method. As I mentioned earlier before, tumor cells can spread directly via myometrial and endometrial carcinoma. In this study, positive MMP9 immunoexpression was seen in 77.8% of tumor evading less than half of myometrial and 91.3% of tumor evading more than half of myometrial, but it was not statistically significant. The findings are in accordance with Karahan et al. And Yu et al., who found no correlation between myometrial invasion and MMP9 expression in their study, with values 0.765 and 0.182 respectively. However, the finding was not consistent with Denizer et al., who found significant relationship between MMP9 expression and myometrial invasion. And so this may be due to small and limited sample size in present study, and further study or increasing sample size would be required. To be concluded, the finding of the study indicated MMP9 regulation in endometrial carcinoma and their role in evasion and metastasis, which might help in assessing prognostic outcome and development of effective treatment and further management of disease. And in this study, very few cases of type 2 carcinoma were obtained, and not our histological type cannot be obtained because they were less common than type 1 endometrial carcinoma, and also due to short time frame of study period. So further study or larger sample size with different histological types were recommended to find out the correlation between MMP9 expression and various histological types. These are my references. And I'm gonna end my presentation here, and thanks everyone for your kind attention.
Thank you, Fusenye, for your presentation. And then, last speaker, please.
Good morning to our professor, chairperson, senior and junior college. I am Dr. Wimami Ao, assistant lecturer from Universities of Medicine 1 Pathology Department. Today, I would like to present a paper on a study of serum thyroglobulin in solitary thyroid nodule. Introduction. Solitary thyroid nodule is a palpable discrete swelling within an otherwise apparently normal thyroid gland. STN occurs in 4 to 7% of adult population. It is present in 5% of persons at an average of 60 years. It is more common in female as compared to male, and this predisposition is estimated incidence of solitary thyroid nodule in adult population of the United States varies between 1 to 10%. In Myanmar, according to obtained from otorhinolaryngology and head and neck surgery specialty hospital Yangon, there were 82 solitary thyroid nodules in 2012, 75 in 2013, and 64 in 2014. Thyroglobulin molecule is the 660 kD glycoprotein composed of 2 identical non-covalently bound subunits. TG specifically represents thyroid tissue, as there is no evidence of transcription of TG gene by non-thyroid tissue. Hence, TG expression is a reliable specific indicator of the presence of thyroid epithelium, either benign or malignant. Most of the study demonstrate a statistically significant difference in mean or median preoperative serum TG value between patients with malignant and benign lesion as final histological report. Nevertheless, overlapping in preoperative serum TG value among these groups was reported. Many researchers document the mean or median TG level in malignant thyroid nodule is greater than benign thyroid nodule. In this study, preoperative serum TG was measured by electrochemiluminescence ECL method. ECL technology is a highly innovative detection technologies for heterogeneous immunoassay. The chemiluminescence reaction is a process in which highly reactive species are generated and they react with one another to produce light. The amount of light produced is directly proportional to the amount of substance measured. This study was undertaken to evaluate serum Tg in solitary thyroid nodule and to find out whether it was related to histological type of solitary thyroid nodule. Since most of thyroid nodules were amenable to surgery or medical treatment, it was hoped that this study would support the clinician for the further management of patients with solitary thyroid nodule. This is the method. This study was a cross-sectional descriptive study. Place of study, Yangon General Hospital, both histopathological and chemical pathological session, otorhinolaryngology and head and neck surgery specialist hospital, University of Medicine 1. This slide shows detailed procedure of the study, clinical and radiological confirmed solitary thyroid nodule cases. Informed consent was taken and patient data was collected. 4 ml of venous blood sample was collected preoperatively. Serum was separated by centrifuge machine with 3,500 RPM for 3 to 5 minutes. Serum Tg level was measured by using Cobas E411. Biopsy specimens were examined and gross picture were recorded. Histological types and serum Tg level are correlated. Let's go to finding. In this study, the age of patients ranged from 18 to 66 years. In a total of 65 patients, there were 11 male patients and 54 female patients. The ratio of male to female was 1:5. There were 45 cases of benign thyroid nodule and 20 cases of malignant thyroid nodule in this study. This table shows histological types of benign thyroid nodule found in this study. Mostly found is the nodular goiter, 23 cases. The second is the follicular adenoma, 10 cases, and the third is the multinodular goiter, 5 cases. The others are the Hashimoto thyroiditis, 4 cases, simple cyst, 1 cases, and chronic lymphocytic thyroiditis, 1 cases. This table shows histological type of malignant thyroid nodule. Papillary carcinoma, 17 cases, follicular carcinoma, 3 cases. The mean value of serum Tg for total 65 cases of solitary thyroid nodule was 225.89 nanogram per ml. The standard deviation was 208.96 nanogram per ml. The minimum value was 0.16 nanogram per ml and maximum value was 500 nanogram per ml. In this study, the cutoff value of preoperative serum Tg was 187.5 nanogram per ml. This table shows association between serum Tg and histological type of benign thyroid nodule. Of the total 35 cases of benign solitary thyroid nodule was less than 187.5 nanogram per ml, and only 10 cases are more than and equal to 187.5 nanogram per ml. These cases include 7 nodular goiter, 2 multinodular goiter, and 1 follicular adenoma. This table shows association between serum thyroglobulin level and histological type of malignant thyroid nodule. Total 17 cases of malignant thyroid nodule was more than or equal to 187.5 nanogram per ml. Only 3 cases of papillary carcinoma thyroid less than 187.5 nanogram per ml. In this study, serum Tg level in solitary thyroid nodule was tested with independent t-test and facial X-ray test. Appropriate statistical analysis was done by using Strata 11.1 version. Significant association was found in independent t-test and facial X-ray test with value less than 0.05. In this study, not all cases of benign thyroid nodule had positive significant level of serum Tg less than 187.5 nanogram per ml. Not all cases of malignant thyroid nodule had serum Tg more than or equal to 187.5 nanogram per ml. So, low level of serum Tg less than 187.5 nanogram per ml cannot exclude the diagnosis of malignant thyroid nodule. But significant increased level of serum Tg more than or equal to 187.5 nanogram per ml were found in malignant thyroid nodule. Discussion. In this study, the total mean value for benign thyroid nodule was 134.4 nanogram per ml and standard deviation was 166.63 nanogram per ml. The total mean value for malignant thyroid nodule was 431.77 nanogram per ml and standard deviation was 135.42 nanogram per ml. Patho et al. State that the mean value of serum Tg for benign thyroid nodule was 172 nanogram per ml and for malignant thyroid nodule was 407 nanogram per ml. In the et al. Study, the mean preoperative serum Tg for benign thyroid nodule was 15.4 nanogram per ml and lowest value of serum Tg for malignant thyroid nodule was 188 nanogram per ml and highest mean value was 278.5 nanogram per ml. The different value of CNTG level observed in literature could be explained by methodology differences and number of samples available. CNTG was measured by using immunoradiometric assay in both Patho et al. And Lee et al. Study. In this current study, it has been demonstrated that 35 cases of benign solitary thyroid nodule were CNTG less than 187.5 nanogram per ml and 17 cases of malignant thyroid nodule were CNTG more than or equal to 187.5 nanogram per ml with a cutoff value of 187.5 nanogram per ml. Patho et al. Showed the cutoff value of CNTG was 400. Carcinoma was present in 44% of patients with TG above 400 nanogram per ml and only 26% of those with TG 400 nanogram per ml or less. In Lee et al. Study, the sensitivity and specificity was 48.5 and 91.5% respectively in solitary thyroid nodule by using the cutoff value of 187.5 nanogram per ml. According to severities of follicular cancer, serum Tg level increased TP, benign versus malignant serum Tg level 15.4 versus 207.8.5 nanogram per ml. However, serum Tg cutoff for predictive indices may need to be individually determined at each center because of variability in thyroglobulin assay. However, higher level of serum Tg was found to be one of the indications for diagnosis of malignant thyroid nodule in this study. Conclusion. In this study, tumor marker serum Tg level was studied in various types of solitary thyroid nodule. As the solitary thyroid nodule became malignant, there is increase in preoperative serum Tg level. It can be concluded that elevated preoperative serum Tg level was associated with increased rate of malignancy. Serum Tg level may be returned to normal after surgery. Serum Tg level can be used in monitoring of thyroid cancer patients during their follow-up period. Serum Tg measurement after surgery can be used to predict the risk of residual disease and recurrence. Because serum Tg significantly contribute to predictive indices, the serum Tg level should be measured regularly in all patients with thyroid nodule who are going to be triaged for observation or surgery. These are my references. Thank you, Siaji, Siamaji, and our professor and associate professor.
Thank you, Wima Miao, for your presentation. I would like to request Professor Doi Mien to invite the next three speakers, please.
Good morning, Chairperson, Professor, Associate Professor, Senior Junior College, and all the distinguished guests. Today, I would like to present my dissertation about immunoexpressions of matrix metalloproteinase 9 in invasive adenocarcinoma breast, no special type. I am Dr. Kim Mijo, Assistant Lecturer from Pathology Department, University of Medicine, Yangon. I would like to introduce that carcinoma breast is the most frequently diagnosed cancer, accounting for 23% of total cancer cases and 14% of cancer deaths worldwide. A man-female breast cancer comprises 25.2% of the total cancer incidence and has a considerably higher incidence rate, 43.3 per 100,000 than any other cancer. According to the data from Registry of Medical and Radiation Oncology Unit, Yangon General Hospital, there were 913 breast cancer cases out of 4696 total cancer cases in 2011, 90.44% of the total cancer cases. 80.94% in 2012, 22.69% in 2013, 90.88% in 2014, and 21.79% in 2015. In Myanmar, the mortality of breast cancer was recorded as 11.8% of the total cancer deaths. Degradation of the extracellular matrix is thought to be a crucial step in the formation of tumor metastasis. Multiple proteolytic enzymes such as plasmin, cathepsin, and matrix metalloproteinase (MMPs) are known to degrade ECM. MMP9 is a zinc-dependent endonucleotide that belongs to the selectinase subfamily of MMPs. It is excreted as an inactive proenzyme that undergoes activation upon cleavage by different types of extracellular proteases. MMP9 degrades type 4 collagen, which is the main component of the basement membrane. MMP9 was found to be significantly overexpressed in grade 2 and grade 3 of IDC breast and plays an important role in tumor evasion and metastasis. As breast cancer is most of the female malignancy in Myanmar, it commonly causes distant metastasis, disease progression, cancer-related morbidity, and mortality. The timely effective treatment can produce prolonged disease-free periods and better prognosis. In this study, the association of immunoexpression of MMP9 and IDC breast NSD will be determined. This study was a cross-sectional descriptive study, and it was conducted at Histopathology section of Department of Pathology YGH and Pathology Research Laboratory, University of Medicine 1, Yangon. A total of 46 histopathologically diagnosed formalin-fixed paraffin embedded tissue samples of invasive carcinoma breast, no special type, were collected from the archives of all the surgical units of YGH. All the 46 blocks were categorized different modified blood resistance grades of IDC breast NSD into grade 1, 2 cases, BR grade 2, 27 cases, BR grade 3, 17 cases. From the representative tissue block, sections of approximately 3 to 4 millimeter thickness were cut and stained by hematologically and eosin stain for histopathological grading. Another section was preceded with MMP9 immunohistochemical staining by using the peroxidase antiperoxidase method. MMP9 immunoexpression was interpreted as initially the whole section was screened at low power to identify the area high positivity. MMP9 immunopositivity was observed as brownish precipitate in the cytoplasm of the tumor cells. In this study, MMP9 immunoexpression was determined by scoring system resulting from multiplying intensity of staining and percentage of positive cells stained in 500 tumor cells. If intensity of staining is negative, score 0. If weak, score 1. If moderate, score 2. And if strong, score 3. Percentage of positive cells stained in 500 tumor cells. If 0 to 25% of cells are stained, score 1. 26 to 50% score 2, 51 to 75% score 3, and 76 to 100% score 4. Immunoreactive score less than 5 was regarded as low expression of MMP9 and more than or equal 5 was high expression of MMP9. Statistical analysis was by SPSS version 16. P-value of less than 0.05 were considered significant. In result, the age distribution IDC breast NSD patients range from 28 to 80 years with mean standard deviation of 48 plus or minus 12.72 years. Among these patients, mostly 41 to 60 year age, mostly had lesion at left side and mostly more than or equal 5 centimeter size. The histology of most of the patient was BR grade 2 and lymph node negative. For staining intensity, 1 case showed negative cytoplasmic staining intensity, 7 cases show weak, 21 cases show moderate, and 17 cases show strong staining intensity. For percentage of positive cells stained in 500 tumor cells, 1 case showed 0 to 25% of positive cells stained, 1 case showed 26 to 50%, 5 cases show 51 to 75%, and 39 cases show 76 to 100% of positive cells stained. Among 46 cases of IDC breast NSD, 8 cases with low IRS and 38 cases with high IRS. Out of 2 cases of BR grade 1, all 2 cases show high IRS. In BR grade 2 cases, 21 cases with high IRS and 6 cases with low IRS. In BR grade 3 cases, high IRS and low IRS were found in 15 cases and 2 cases respectively. Among 46 cases of IDC breast NSD, 21 cases were isolated lymph node positive and 25 cases negative. Out of 21 positive cases, 17 cases with high IRS, 4 cases with low IRS. Out of 25 negative cases, 21 cases high IRS, 4 cases low IRS. These are photos of invasive carcinoma breast BR grade 2 comparing H&E stain and MMP9 IRS 8. These are BR grade 3, comparing HNE stain and MME9, IRS 12. I would like to discuss that breast cancer is the most widely recognized tumor affecting women in the world today. It is the leading cause of death in women, while 1 million of women are determined to have breast cancer consistently, accounting for a tenth of all new cancer. Tumor cells employ one of their proteolytic enzyme, MME9, to cleave the extracellular matrix and invade the surrounding tissue. Moreover, MME9 promotes tumor neovascularization by specifically activating angiogenetic factor at the cancer cell matrix. In this present study, 46 cases of IDC breast NSD were studied. Histological grading, modified blood resistance grading was determined, and immunoexpression MME9 was detected. Then the association between MME9 immunoexpression and different histological grades and isolate lymph node data were evaluated. 45 out of 46 cases of IDC breast NSD expressed positive MME9. Among 45 MME9 positive cases, 38 cases were all high IRS. Regarding the association MME9 immunoexpression with histological grade, among 46 cases of IDC NSD, all cases of BR grade 1 high IRS, BR grade 2, 21 cases were of high IRS, and BR grade 3 cases, 15 cases were of IRS. In this study, there was no significant association between MME9 immunoexpression, histology, modified blood resistance grading, or invasive carcinoma breast. For better interpretation of the results, some inadequacy in this study should be acknowledged. Discrepancy among variety of factors, study design, ethnic factors, and number of cases. This may be due to the fact that present study is limited by the small number of cases and short duration of study period. A larger study of longer duration rendered to confirm the immunoexpression MME9 in invasive carcinoma breast NSD. Therefore, the impaired association of MME9 immunoexpression on different histological grades still needed to be further confirmed by adequately designed study. Although there is no significant association in this study, MME9 is one of the interesting target factors in the mechanism of metastatic cases with high MME9 immunoexpression. Higher expressions of MME9 protein by tumor cell was associated with high rate of metastasis. It also correlated with lymphangiogenetic factor, lymphatic metastasis, and poor prognosis in breast cancer. MME9 show a strong immunostaining in patients who died with metastasis. There was no expression of this marker in normal breast tissue. Therefore, MME9 may be a candidate for close follow-up to have awareness of metastasis. Targeted therapy with MME inhibitor may be applicable in the future. I would like to conclude that regarding the immunoexpression MME9 in different modified blood resistance grade, high MME9 immunoexpression was not significantly associated. P-value equals 0.539. It also not associate with isolated lymph node data, p-value equal 1.00. Although there is no significant association in this study, MME9 have a role of diagnosis purpose in the detection of primary tumor and metastatic tissue in combination with other important markers, vascular, molecular, and genetic factors. Therefore, further granted studies are recommended to reinforce this study of interest in MME9 immunoexpression. These are my references. Thank you for your kind attention.
Thank you. Now I will invite the next speaker, which is also MME9 immunoexpression and CSRX.
Good morning to our honorable chairperson. Good morning to our honorable chairperson, professor and head professor, associate professor, seniors and junior colleagues. I am Dr. Pyo Mimi, assistant lecturer from University of Medicine 1 Yangon, Department of Pathology. Today, I would like to present matrix metalloproteinase 9, MME9 immunoexpression in squamous cell carcinomas or cervix. Cervical cancer is one of the most common female malignancy in Myanmar. It shows extensive local tumor invasion and distant metastasis. Squamous cell carcinoma is the most common neoplasm on cervix. MME9 is a proteolytic enzyme which is major contributor of tissue breakdown and reconstitution of extracellular matrix, causing destructive disease, tumor progression, and widespread metastasis. The aim of this study was to study the immunoexpressions of MMP9 in squamous cell carcinoma or cervix. Objectives are to categorize the histological grades of squamous cell carcinoma or cervix, to determine immunoexpressions of MMP9 in above cases, to find out the association between the immunoexpressions of MMP9 in different histological grades or SEC or cervix. This study was a cross-sectional distributed study. This study was carried out within 1 year. The place of studies are all gynecological oncology unit, Central Women Hospital, Histopathology Section, Department of Pathology, Central Women Hospital, the Pathology Research Laboratory, Department of Pathology, University of Medicine 1, Yangon. These are the slides showing materials and method. Methodology. All new cases or histologically proven squamous cell carcinoma or cervix are updated, taking the informed consent after the H&E staining of the tissue and examination by ordinary light microscope, and the histological gradings of squamous cell carcinomas of the cervix. After the IC staining with MMP9 monoclonal antibody, histological grades of SEC or cervix are classified according to the immunohistoretic score. Determinations of association between MMP9 immunohistoretic score and histological grades of squamous cell carcinoma or cervix. Data analysis and writing dissertation. Regarding the interpretations of MMP9 immunoexpression, MMP9 immunopositivity was observed brownish cytoplasmic staining of the tumor cell. In the study, MMP9 immunoexpression was determined by scoring system using the multiplications of intensity of staining and percentage of positive cell stain. Regarding the intensity of staining, score 0 means colorless, score 1 means weak staining, score 2 means moderate staining, score 3 means strong staining. Regarding the percentage of positive cell staining in 500 tumor cells, score 0 means 0 to 5% of the cells, score 1 means 6 to 25%, score 2 means 26 to 50%, score 3 means 51 to 75%, and score 4 means 76 to 100%. Immunoreactive score range 1 to 12 score. These are the results showing this study. Regarding the age distribution of the patient in squamous cell carcinoma of the cervix, in this study, age group of 40 to 59 were mostly affected. The mean age of the patient was 48 plus or minus 12.72 years. Regarding the marital status, 89% were married, 11% were single. Regarding the parity status, parity between 1 to 4 group was majority of cases. Regarding the histological grades of patient with squamous cell carcinoma of the cervix, 78% were moderately differentiated, 14.5% were poorly differentiated, and 7.5% were well differentiated. Regarding the staining intensity, 62% were score 2, moderate staining, 27.3 were score 1, weak stainings, and 10.7% were score 3, strong staining. Regarding the percentage of positive cell in the squamous cell carcinoma or cervix, 24 cases were score 3, 23 cases were score 2, and 4 cases were score 1. Regarding the association between the immunoreactive scores of MMP9 and histological grades of squamous cell carcinoma or cervix, the appropriate analysis was done by using the ANOVA test. Minimal differentiation was 1 in well differentiated, 2 in moderately differentiated, 6 in poorly differentiated. Maximum differentiation was 2 in well differentiated, 9 in moderately and poorly differentiated. There was a positive association between the MMP9 and different histological grades of squamous cell carcinomas of the cervix, P equals 0.000. This is the slide showing the H&E staining of well-differentiated squamous cell carcinomas of cervix. This is the slide showing the H&E staining of moderately differentiated squamous cell carcinoma or cervix. This is the slide showing the H&E staining of poorly differentiated squamous cell carcinoma or cervix. This is a slide showing the IC stainings of MMB9 immunoreactive score 2 in world differentiated squamous cell carcinoma survey. This is the slide showing the immunoreactive score 6 in moderately differentiated squamous cell carcinoma surveys. This is the slide showing the immunoreactive score 9 in poorly differentiated squamous cell carcinoma or surveys. Discussion. It was also found that higher expressions for MMB9 was frequently detected in high histological grades. Lee et al. In 2012 found MMB9 high expression was roughly 70% in well differentiated, 75% in moderately differentiated, 100% in poorly differentiated squamous cell carcinoma or surface. You et al. In 2016 showed that higher expressions of MMB9 are frequently detected in cervical cancer with destromal invasion and vascular invasion. Methods et al. In 2012 showed that 90% of the SEC surface express positive MMB9 expression. Cluster et al. In 2016 state that 32 out of 43 cases show high expressions of MMB9 in squamous cell carcinoma or surface. So the results of this study was in accordance with other international studies. In this study, there was significant association between MMB9 immunoexpressions and histologic gradients of squamous cell carcinoma or surface. MMB9 immunoexpression was significantly different with different histological gradients of squamous cell carcinoma or surface. MMB9 immunopositivity increased when the tumor became poorly differentiated. Overexpression of MMB9 was more frequently detected in cervical cancer with destromal invasion, advanced fecal state, positive lymph node metastasis, and vascular invasion. MMB9 was expressed in 95% of the invasive squamous cell carcinoma or surface. Conclusion. The finding of this study showed that there was significant association between MMB9 immunoexpressions and different histological grades of squamous cell carcinoma or survey. It indicates that there was correlation of positive MMB9 immunoexpressions and tumor aggressiveness. This finding could be highlighted the role of MMB9 immunoexpression in the assessment of prognosis outcome of cervical cancer. MMB9 immunoexpression could be considered as a potential IC marker for assessing the progression of the lesion to a more severe degree of histological gradient. This study highlighted that immunoexpressions of MMB9 can predict the disease severity. Therefore, MMB9 immunoexpression may be a candidate for close follow-up to have awareness of metastasis and targeted therapy with MMB9 inhibitor, which is eligible in the future. These are the reference. Thank you for your kind attention.
And now xong theo khỏi lại mình nó. Vì sẽ Q&A lúc đến nó. Okay. Last speaker.
Good morning. Good morning, chairpersons, professors, NCI junior and the senior colleagues. Today, I would like to present about the serotonin-5 hydroxy vitamin D status in patients with multiple myeloma. Multiple myeloma is one of the most common hematologic malignancies with 176,404 new cases and 117,007 deaths worldwide annually in 2020. In the United States, estimated numbers of new cases of multiple myeloma was 30,280, and about the 12,590 died from the multiple myeloma in 2017. According to data from Department of the Clinical Hematology, YGH, the total numbers of the new multiple myeloma cases with confirmed bone marrow results were as follows. This figure shows updated investigations and increased awareness of the disease, leading to the increased incidence of the multiple myelomas in Myanmar. Multiple myeloma is a B-cell malignancy characterized by the proliferation of a single clone of the plasma cells that produce a monoclonal immunoglobulin proliferation. The plasma cell proliferation results in extensive skeletal involvement. Osteoclasts in bone marrow microenvironment play a crucial role in pathophysiology of multiple myeloma and associated bone disease. Skeletal complications are the major cause of morbidity. These skeletal-related events compromise mobilities and independence, adversely affect quality of life, and associated with decreased survival. Vitamin D is a fundamental mediator of the skeletal metabolism due to its ability to stimulate the absorption of the calcium and phosphate across the intestinal mucosa and to promote the bone mineralization. Vitamin D also controls the several critical cellular processes. There is an inverse association between the 25-hydroxy D levels and cancer risks in humans. Vitamin D also has a significant clinical role in multiple myeloma patients because of their interrelationship with calcium homeostasis and bone metabolisms. Moreover, vitamin D level decreases pro-inflammatory cytokines and rings in the negative pathological activations of these stem cells, which are playing a key role in the multiple myeloma pathophysiology. Vitamin D deficiency and insufficiency is widely prevalent in patients with multiple myelomas. It is also associated with the increased ISS stage of the multiple myeloma. This theory aimed to find out the correlations between the serum 25-hydroxy vitamin D status and different stages of the multiple myeloma. It was hoped to get the information of the significance of the vitamin D deficiency in assessment of disease prognosis of the multiple myeloma. It might support the further management of the disease. Method. This theory was a hospital-based cross-sectional descriptive study. It was conducted at the chemical pathology sections, Department of the Pathology YGH, and Department of the Pathology UM1. Total 37 cases of the multiple myeloma patients were studied between the July 2018 to the June 2019. For the selections of the participants, inclusion criteria were all new cases of the diagnosed multiple myeloma. For exclusion criteria was any patients treated with vitamin D supplementation before sampling, history or current use of the drugs which may affect the vitamin D level except the prednisolone, any patients with evidence of the chronic liver disease, any patients with evidence of the malabsorption syndromes. Informed consent from patients were obtained. After obtaining the informed consents, patients' particular and detailed history were recorded. The clinical stages of the multiple myeloma were studied and categorized by ISS as ISS stage 1 as serum beta-2 microglobulin less than 3.5 milligram per liter and serum albumin more equal 3.5 gram per deciliters. For ISS stage 2 is not ISS stage 1 or 3. For ISS stage 3 is serum beta-2 microglobulin more equal 5.5 milligram per liters. Under aseptic condition, about 2 ml of venous blood were taken and dispensed in the plain tube. There was no need for fasting and no special preparation. Blood samples were labeled and sent to chemical pathology section as soon as possible. During the transportation of the blood sample to the laboratory, tube was wrapped in the aluminum foil for preventing the blood from exposure to sunlight. At the laboratory, tube was kept in the sliding position and allowed the blood to clot at the room temperatures. After 15 to 30 minutes, loosen the cloth slowly and by using the micropipette and transfer the separated serum into the centrifuge tube and centrifuge it and the 3,500 RPM for 10 minutes by centrifuge machine. Pale yellow color serum was obtained. Obtained serum was transferred to a clean and dry test tube by using the Pasteur pipette. Labeled in the stopper appropriately and immediately stored at 228 degrees Celsius till it was used to perform a test. Serum vitamin D level was measured by electrochemiluminescence method used by the fully automated immunoassay analyzer COBAS E411. After the results of the serum vitamin D levels had done, cutoff points were categorized as less than 30 nanogram per ml as a vitamin D deficiency and 30 nanogram per ml and over as a vitamin D sufficiency or normal. The association between serum vitamin D status and different stages of the multiple myeloma was found out. For the data analysis, simple discrete analysis for each single variable was done. One-way annual was used to test the hypothesis of the vitamin D levels with the stages of the multiple myeloma. P-value less than 0.05 was the consistent statistical significance by using SPSS version 20.0. These are my results in this study. 37 cases of the multiple myeloma patients were the study. Age of the group was the range from the 46 to the 83 year. 21 patients were the male patients and the 16 patients were the female patients. Majority of the patients in was the ISS stage 2. Serum 25-hydroxy vitamin D status in patients with multiple myeloma was 28 out of 37 patients with the vitamin D deficiency and the 9 patients with the normal vitamin D levels. This was my association between the serum 25-hydroxy vitamin D status, all the stage 1 patients with the normal vitamin D levels, ISS stage 2, 11 out of 19 patients with the vitamin D deficiency, and all the ISS stage 3 patients with the vitamin D deficiency. For the main difference between the different stages of the multiple myeloma and vitamin D status, p-value was 0.00, which showed that statistically significant. that the highest vitamin D levels were found in the stage 1 and the lowest vitamin D level was found in the stage 3. For my discussion, updated investigation procedures and increased awareness of the disease allowed the disease to find out early, leading to increased incidence of the multiple myeloma. Although treatment performance is improved, during these years, mortality and morbidity are still high. Skeletal-related abnormalities are the most common cause of the morbidity. In this study, age of the patient ranged from the 46 to the 83 years with the mean age of 63.81 plus or minus 10.84 years. Majority of the patients were between the 61 to 80 years. The results of the studies and other studies showed that the prevalence of the multiple myeloma was found to be the highest among age group over the 60 years. In this study, there were 21 male patients and 16 female patients. Male to female ratio was approximately 1.3:1, which showed that male was slightly more affected than the females. The results of the present study were the correspondent with the other studies and showing that there was a male preponderance in the multiple myeloma cases. Among the study population, majority of the patients were ISS stage 2, 51.4%, 29.7% were ISS stage 3, and only the 18.9% were ISS stage 1. These results were corresponding with the findings of the Swiss-Mali, where the majority of the patients were ISS stage 2, and these patients were associated with the highest incident target organ impairments at the time of their diagnosis. Yokus et al. 2017 found that the majority of the patients were ISS stage 3, 35.48% were ISS stage 2, and only the 16.13% were ISS stage 1. These results indicated that most of the cases were presented with advanced stage of the disease at the time of the diagnosis. Raven Bosch et al. Showed that the serum vitamin D level was sufficient in less than two-thirds of their patients. Lauders and Skidmore-Wolf 2015 found that among the 83 patients, only the 13.3% had the normal vitamin D levels. Another relevant study of the Yogus et al. 2017 reported that mean vitamin D levels of all patients were 11.9 plus or minus 7.6 nanogram per ml. Vitamin D level were deficient in 29 out of the 31 patients. In this study, maximum vitamin D level was 43 nanogram per ml with a minimum 12 nanogram per ml. 28 out of 37 patients were in deficient state, and the 9 patient has a normal vitamin D levels. Therefore, the results of the present study was consistent with these previous international studies, indicated that vitamin D deficiency was widely prevalent in patients with multiple myeloma. Yellow Prakrata et al. 2020 study, a cohort of the 1,889 patients with multiple myeloma, where serum 25 hydroxy vitamin D level was measured and monitored within 2 months following diagnosis. Overall, patients with vitamin D deficiency had an elevated estimated mortality risk of 24%, p-value 0.02. Therefore, they reported that importance of the screening of vitamin D deficiency at the diagnosis in multiple myeloma and vitamin D supplementation have been beneficial to multiple myeloma patients. In the studies of the Clement et al., musculoskeletal pains recover markedly within the 4 months with vitamin D replacement. This indicated that vitamin D plays a major role in musculoskeletal system pains in patients. Therefore, they suggested that vitamin D level should be investigated in patients with such complaints. Nagy et al. 2009 found that vitamin D deficiency was detected in 16% of their patients categorized as ISS stage 1, 20% of patients in ISS stage 2, and 37% of patients categorized as the ISS stage 3. There was p-value was 0.03, shows statistically significant difference between the vitamin D levels and ISS stages. In this study, all the ISS stage 1 patients were in normal vitamin D levels. Among 19 cases of the ISS stage 2 patients, 17 cases were in vitamin D deficient states, and all the ISS stage 3 patients were in vitamin D deficient. The highest mean of vitamin D level was observed in the stage 1 cases, and the lowest mean of vitamin D level was found in the stage 3 cases. P-value was 0.03, which showed that there was a statistically significant difference of the vitamin D status among the different stages of multiple myeloma. The results of this present study was consistent with the findings of the Nagy et al. And indicated that the percentage of the newly diagnosed multiple myeloma patients with vitamin D deficiency increased in stepwise manner with progressively higher ISS categorization. Therefore, these findings suggested that vitamin D deficiency might be predictive of a poorer outcome in multiple myeloma. For my conclusion, according to the results of this present study, most of multiple myeloma patients were over the age of the 60 years, and the further decrease in vitamin D levels indicated the high ability to cause multiple myeloma-related bone complication. The prevalence of vitamin D deficiency among the study population was found to be significant. As the ISA stage of the multiple myeloma advance, there was low in vitamin D status. The results confidently reveal the association between the ISS stage and the vitamin D deficiency in Myanmar patients with statistical significance. ISS also has an important prognosis significance. Therefore, it could be postulated that vitamin D deficiency can be considered poor prognosis factor for multiple myeloma patients. More interventional studies are needed to determine whether vitamin D supplementation can prevent and or retard the progression of multiple myeloma disease activity. Larger population-based studies are needed to assess the role of the vitamin D deficiency in disease progressions, overall survival, and quality of life in subjects with newly diagnosed multiple myeloma. Since there are only a few studies focusing on the role of the vitamin D supplementation resolve the bone pain, which is the common presentation of multiple myeloma, we hope that this study might contribute some interest and information for further research in our country in the futures. These are my references. Thank you for your attention.
Thank you, Ban Isre, and all the presenters. Now this is the time for the question and answer section. And we have now left with the 25 minutes for the question and answer section. So as I see in the chat box, there are 16 questions for these papers. Question number 1. So speaker 1, how about the prothrombin and diabetes mellitus? This factor may also be responsible for microvascular complications of diabetes mellitus. Why didn't you do that? Speaker 1 ငါဖြေပေးပါဦး။
Okay ပါဆရာကြီးဟုတ်မမမေးတာဟုတ်ပါတယ်ဆရာကြီးပြီးသူတို့မင်းတိုင်းရလဲဒီ risk မှာပါပါတယ်ဒါပေမဲ့ paper တော်တော်များများတော့ဆရာကြီးဟို APTT နဲ့ဒီ fibrinogen hemoglobin A1C ရဲ့ဒီ၃ခုကိုပေါ့နော်တော်တော်များများရှာထားတာလည်းဖြစ်ပါတယ်ဆရာ PT နဲ့ရှာထားတာရှိတော့ရှိပါတယ်ဆရာနည်းနည်းပါတယ်ဆရာအဲ့ဒါလည်း APTT ကိုပဲအဓိကထည့်ပြီးတော့ရှာထားတာပါဆရာ
။ Increased fibrinogen case associated with the poor glycemic control တဲ့ဟုတ်
โอเคဟိုအဲ့ရဆရာမကြီးမိရတာပါဟုတ်ပြပါတယ်ဟိုဆရာမကြီးမိရတာက fibrinogen level ဟို association တော့ရှိမရှိဆိုတာခုမှချတာပါဆရာကြီး paper မှာပြောထားတာတော့ correlation ရှိတယ်လို့တော့ပြောထားပါတယ်ဆရာကြီး poor ဆရာမကြီးက poor glycemic control patient တွေမှာပေါ့နော်ဟိုအဓိက fibrinogen များရင် thrombotic ဒီ atherosclerosis ဖြစ်ဖို့ risk တွေကပိုပြီးတော့များတဲ့အတွက် poor တွေနဲ့ association ရှိလားဆိုပြီးတော့ရှာကြည့်တာပါဆရာကြီး
Okay. Now, Speaker 2, do you recommend the routine use in the endometrial carcinoma?
Endometrial carcinoma မှာကကြောင့်သူကကြောင့်ဒီ disease ကပေါ့နော် risk of recurrence နဲ့ metastasis ကများတဲ့အတွက်ကြောင့်မို့လို့ပေါ့နော်ဒီ MMP9 ကိုယ်တိုင်ကလည်းသူက invasive nature ကိုပြတယ်ဒါကြောင့်မို့လို့ကဲဒါဟို endometrial cancer က low grade ဖြစ်ပေမဲ့ဒီ MMP9 expression က strong expression ပြနေရဆိုလို့ရှိရင်သူ disease ရဲ့ nature က invasive nature ရှိနေရလို့ယူဆတဲ့အတွက်ကြောင့်မို့လို့ပေါ့နော်တကယ် routine သုံးနိုင်တယ်ဆိုလို့ရှိရင်တော့သူ့ရဲ့ invasion ကိုစောစောစီးစီး recognize လုပ်ပြီးတော့ effective treatment ပေးနိုင်လို့ရှိရင်တော့ပိုကောင်းမယ်လို့ထင်ပါတယ်ဟုတ်
What is the proper tissue used for the positive control of MMP9?
According to literature နဲ့ research paper တွေအရကတော့ proper tissue ကတော့ either colorectal cancer or breast carcinoma လို့တော့တွေ့ထားပါတယ်ဆရာကြီးဟုတ်
Other histological types rather than the endometrioid and the serous carcinoma.
ဒီသမီး study မှာတော့type 1မှာ endometrioid carcinoma နဲ့ type 2မှာတော့ serous carcinoma ပဲရခဲ့ပါတယ်ကျန်တဲ့ other histological type တွေတော့မရခဲ့ပါဘူးရှင်ဟုတ်
Then speaker 3, nodular goiter and multinodular goiter, any different in histology? Speaker 3.
Okay, ဆရာရှင်ဟို ဟုတ်ကဲ့ပါဆရာမကြီးဟိုသမီးကတော့ difference မရှိဘူးလို့တော့ထင်ပါတယ်ဆရာမကြီး။ तू ကတော့ဟို gross နဲ့ပဲကြည့်ပြီးတော့ nodular ဟိုများတယ်ဆိုရင် multinodular လို့ပြောင်းလိုက်တယ်လို့ထင်ပါတယ်ရှင်
So how about the thyroglobulin in medullary carcinoma thyroid?
medullary carcinoma thyroid ကကြတော့သမီးတို့ thyroglobulin ဆိုတာသူက follicular cells ကနေ follicular cell ကနေထွက်တာဆိုတော့သူက medullary ကကြတော့ neuroendocrine cell ဆိုတော့သူကအဲ့မှာတော့တက်မှာမဟုတ်ပါဘူးဆရာကြီးရှင်
How about the anaplastic thyroid carcinoma?
anaplastic thyroid carcinoma မှာဆိုလို့ရှိရင်လေသူက thyroid follicles တွေကဟိုမရှိဘူးပေါ့ no evidence of thyroid follicles တွေဖြစ်နေတဲ့အတွက်ကြောင့်အဲ့ဒီမှာလည်းမတက်တော့ဘူးလို့တင်ပါတယ်ရှင်သူက different well differentiated thyroid carcinoma ဖြစ်တဲ့ follicular နဲ့ papillary မှာပဲပို့ပြီးတော့တက်ပါတယ်ရှင်
So can TG differentiate them according to the literature? According to the literature, can the thyroglobulin can differentiate these medullary thyroid carcinoma and anaplastic thyroid carcinoma?
ခွဲလို့မရဘူးလို့ထင်ပါတယ်ရှင်
Okay, speaker 4. Do you recommend the MMB in the routine use in the cancer breast and why?
ဟုတ်ကဲ့ဆရာကြီး routine မှာ3နိုင်တော့ပိုကောင်းမယ်လို့ထင်ပါတယ်ဆရာကြီးသူက cancer မှာလည်း express လုပ်တယ် invasive nature ကိုလည်းသိနိုင်တယ်ဆိုတော့စောသိလို့ရှိရင် inhibitor တွေပြီးပြီးတော့ပို့ပြီးတော့ targeted therapy လည်းသုံးလို့ရတယ်ဆိုတော့routine မှာ3နိုင်တော့ကောင်းမယ်ထင်ပါတယ်ဆရာ
How about MMB9 immunoexhaustion in DCIS areas?
DCIS မှာလည်း express လုပ်ပါတယ်ဆရာကြီးတမီးကတော့အဲ့တစ်ခု case တစ်ခုပဲလုပ်ထားတော့ထည့်မရပါဘူးဆရာကြီးတခြားDCIS paper တွေထဲမှာကျတော့ DCIS ကနေပြီးတော့ invasive ကိုဆက်မသွားတော့ဘူးเนาะ inhibitor သူတို့ရဲ့ trial တွေမှာ inhibitor ပေးလိုက်လို့ရှိရင် DCIS ကနေ invasive cancer ကိုဆက်မပြောင်းတော့ဘူးလို့ပြောပါတယ်ဆရာ
So when do you think the ethnicity has impact on the MMB9 immunoexpression?
Ethnicity မှာဆိုလို့ရှိရင်တော့ paper ရဲမှာကတော့ဆရာကြီးသူကSouthern Chinese တို့ကမာတို့အဲ့ဒီလူမျိုးတွေမှာဆိုပို့ပြီးတော့ MMB9 နဲ့ပို့ပြီး associated ဖြစ်တယ်လို့တွေ့ဘူးပါအဲ့နဲ့လိုက်ပြီးတော့ invasive nature ကလည်းကွာသွားတယ်လို့ပြောပါတယ်ဆရာကြီး
DCIS leases 46 cases are new cases within the study GLR.
New cases မဟုတ်ပါဘူးဆရာကြီး previous 1 years ကနေပြီးတော့ကောက်ထားတာပါဆရာကြီးဒီ new cases တော့မဟုတ်ဘူးဆရာကြီး old cases လို့ပဲပြောမှာပါဆရာ
Now speaker 2 meter. How about the clinical trial of MMB9 inhibitors for endometrial carcinoma? Clinical trial.
ဟုတ်ကဲ့အခုလောလောဆယ်တော့ trial လုပ်နေတဲ့ဆေးတစ်မျိုး Marimaster ဆိုတာရှိပါတယ်သူက broad spectrum MMB inhibitor ပေါ့နော် not only MMB9 but also MMB1 2 3နဲ့7ကိုပါ inhibit လုပ်နိုင်တယ်ဆိုရယ်ဆေးတစ်မျိုးတော့ trial လုပ်နေတော့မှာဟုတ်
Speaker 5 did you look for the lymphovascular invasion in the cervix? How about the MMB9 expression in these cases? How about the histological types in single victims of CA cervix?
ဟုတ်ကဲ့ပါဆရာကြီးlymphovascular invasion တော့တမီးမကြည့်ခဲ့ပါဘူးဆရာကြီးတမီးကကြတော့ဒီ histological grades တွေသူရဲ့ differentiation တွေနဲ့ MMB9 immunoexpression ကိုကြည့်ခဲ့လို့ပါဆရာကြီးဒါပေမဲ့ literature တွေအရကတော့သူက MMB9 immunoexpression ပိုဆိုးလေ lymphovascular invasion ပိုဆိုးလေလို့တော့တွေ့ရပါတယ်ဆရာကြီး
Okay. Do you recommend the MMB9 in routine use and why?
ဟုတ်ကဲ့ပါဆရာကြီးဒီ CA service ကမြန်မာနိုင်ငံမှာလည်းအဖြစ်များတယ်ပေါ့နော်လာတာလည်းသူက local invasion တွေကလည်းများတယ် distant metastasis တွေကလည်းများပါတယ်ဆရာကြီး MMB9 ဒီ immunoexpressions ကို routinely မှာသုံးနိုင်တော့ပို့ပြီးတော့ကောင်းပါတယ်ဆရာကြီးသူကသူ့ရဲ့ local invasion တွေ distant metastasis တွေ MMB9 expression ဆိုးလေးပိုဆိုးလေးတွေ့ရတဲ့ကြောင့်မလို့ lymphovascular invasion တွေဆိုလေးတွေ့ရတဲ့ကြောင့်မလို့ပို့ပြီးသုံးနိုင်တော့ပို့ပြီးတော့ကောင်းပါတယ်ဆရာကြီး
Most of SCC of the cervix are treated by radiation. Any clinical trial of MMB1 alone or together with the radiation and treatment of these patients?
ဟုတ်ကဲ့ပါဆရာကြီး Stay treatment အနေနဲ့ကတော့ squamous cell carcinoma service မှာတော့ radiation တွေ3လုံးမှာဆရာကြီး3အများဆုံးမှာ clinical trial အနေနဲ့ဒီ MMP inhibitors တွေကိုလည်း trial တွေလုပ်နေပါတယ်သူ့ကို radiation နဲ့တွဲသုံးမှုအတွက် neo adjuvant တွေ adjuvant therapy တွေ targeted therapy အနေနဲ့တော့ trial တွေရောလုပ်နေတဲ့ literature တွေတော့ရှိပါတယ်ဆရာကြီးရှင်
Then speaker 6 can D3 supplementation cutoff values are higher in your set. ကြားလားမသိဘူးဆရာပြောတာ
ဟုတ်ကဲ့ပါဆရာကြီးvitamin D supplementation ကိုတော့သူတို့အခုပေါ့နော်ဆရာကြီးနောက်ပိုင်းထွက်တဲ့2020မှာဒီနှစ်ထဲမှာထွက်ပြီးခဲ့တဲ့နှစ်ကမှထွက်ထားတဲ့ study မှာတော့ vitamin D supplementation တွေကိုသူတို့သုံးပေးပါတယ်ဆရာကြီးဒါပေမဲ့သူတို့ကဘယ်လိုမျိုးပေးလဲဆို bone lesion ကို vitamin D low level ဖြစ်တဲ့ less than 20 nanogram ပါမေးမှာဆိုလို့ရှိရင်သူတို့ကစပြီးတော့ပေးတယ်ဆရာကြီးပြီးလို့ရှိရင်သူတို့ကbone lesion တွေကိုသူတို့ကဘယ်လိုမျိုးစစ်ပြီးတော့လဲဆိုလို့ရှိရင်သူတို့က CT ရိုက်တယ်ပြီးလို့ရှိရင် bone density matrix တွေကိုသူတို့ကတိုင်းပြီးတော့မှသူတို့အခု study လည်းလုပ်နေပါတယ်ဒါပေမဲ့အဲ့ result ကတော့သူတို့က ongoing ဆိုပြီးတော့ပဲဒီ Yellow Bragado et al 2020 blood advance ကနေသူတို့ကထုတ်ထားတာပါ overall survival rate ကိုပဲသူတို့ကပြီးခဲ့တဲ့2019မှာပေါ့နော်အဲ့ result ကထွက်ထားတာလေးပဲရှိပြီးပါတယ်ဆရာကြီးပြီးတော့ cut off values are height in ဆိုတာကြတော့သမီးပေါ့နော်သမီးတို့သုံးတဲ့ဟာကြတော့ Copex E411 နဲ့သုံးတာပါဆရာကြီးအဲ့ထဲမှာသူကပေးထားတာ healthy reference value recommended for use အနေနဲ့သုံးထားတာကကြတော့သူ့ရဲ့many expert တွေကနေပြီး more or equal 30 nanogram per ml ဆိုလို့ရှိရင်တော့သူတို့က normal vitamin D level ဆိုပြီးပြောတဲ့အတွက်ကြောင့်သမီးရဲ့ paper ဒီသမီးလုပ်တဲ့ဒီ set Copex E411 နဲ့ run တာဖြစ်တဲ့အတွက်ကြောင့်ဒီ cut off values ကတော့higher တော့ဖြစ်နေတာပါဆရာကြီး
အဲ့တော့ဒီ vitamin D ကိုသုံးနေသလား multiple myeloma မှာ nowadays
ဟုတ်ဆရာကြီးပေါ့သူတို့ vitamin D ကတော့သူတို့ deficiency ဖြစ်တယ်ဆိုရင်တော့သူတို့ကသုံးပါတယ်ဆရာကြီးဒါပေမဲ့ဒီပေါ့နော် multiple myeloma မှာတော့သူတို့သုံးမယ်ဆိုလို့ရှိရင်တော့အဲ့တခြား matrix တွေ CTs တွေဘာတွေရိုက်ပြီးတော့မှပဲသုံးတာကိုပဲတွေ့သေးတာပါဆရာကြီး
histological types in single victims of CSA ပြီးသွားတယ်အဲ့မိကွာနော်
ဒီအသေးလို့ဆရာကြီး
ဟုတ်ကဲ့ဆရာကြီးတမီးဟုတ်ကဲ့ပါမမအဲ့ဒါဟိုကလေမမ तू တမီးအခုလောက်ခဲ့တဲ့နေရာမှာတော့ तू ဟို marital status နဲ့ပတ်သက်ပြီးတော့ဟို merit တွေက SCC အများဆုံးအဖြစ်များတယ်ပေါ့နော်မမဆိုလိုချင်တာ तू ဟို single ဆိုရင် histological type ကဘာ type ဖြစ်ရှင်းမမ
အဲ့ဒါပြောတာ
ရှင်းမမတမီးမကြားနိုင်ဘူးမမ
သမီးရဲ့လေသမီးရဲ့လေ description ထဲမှာ single လဲပါတယ်ဟုတ်ကဲ့6ရောက်လောက်သိပါတယ်
ဟုတ်ကဲ့ပါဟုတ်
အဲ့ဒီလူရဲ့ histological type ကိုမသိချင်တာ
ဟုတ်ကဲ့ပါမမ
depression
အဲ့ဒါပဲမမဟိုပါပဲ तू က SCC ပဲမမဟုတ်ကဲ့ဟုတ်အဲ့ single တွေရတယ် SCC ပဲတမီးကဟို SCC တွေပဲယူတာမမ CA service က SCC တွေကိုပဲယူတာမမအကုန်လုံးကဟိုကအဒီနိုတခြား other types တွေမပါဘူးမမ
any more တော့စမိုင်းတို့မြေကျွန်တော်ဗာမေးစရာရှိသေးလဲဗာပြောစရာရှိသေးလဲ
ပါဟုတ်ဆရာကြီး
Any more question from the floor? Any more question from the other participants?
အကုန်လုံးလေးဆရာကြီးဟိုပါပေါ့နော်ဟို MMP9 တွေအများကြီးလောက်သွားတော့အဲ့ဒီ MMP9 တွေကနော်သမီးတို့အားလုံးကတယောက်နဲ့တယောက် control တွေလည်းမတူကြဘူးပေါ့နော်
ဟုတ်ကဲ့ပါ
မတူကြဘူးဆိုတဲ့အခါကျယူတဲ့ control တွေမတူဘူးလေနော်တယောက်နဲ့တယောက်ကသူကတကယ်လို့အဲ့ဒီ clone ပေါ့နော် clone က biogenics ကလုပ်တယ်အဲ့တော့ biogenics ကရတဲ့ clone နဲ့ compatible ဖြစ်တဲ့ optimal control tissue ကဘာ tissue လဲမသိဘူး
သမီးရဲ့ study မှာじゃ normal lens tissue ပါ
ဟုတ်ပြီ
ဟုတ်မမသမီးနဲ့ literature ထဲမှာတွေ့ရ lens ပဲမမ
ဟုတ်တယ်နော်အဲ့တော့အဲ့ဒီ lens ကိုသမီးတို့အကုန်ယူထားကြတယ်ပေါ့
ဟုတ်ကဲ့ပါမမ lens ပါပဲ
အဲ့ဒါပြောတာနော်သူကလုံးနဲ့သူ့ရဲ့ tissue ပေါ့နော်
ဟုတ်ကဲ့ပါမမ
thank you ပါ
ဟုတ်ကဲ့
အမကျေးဇူးပါ
ကျေးဇူးတင်ပါတယ်
We are If there is no more questions ဆိုရင်ကျွန်တော်နည်းနည်းလေးပြန်ပြီးတော့ wrap up လုပ်ချင်ပါတယ်ဒီပထမဆုံးအားလုံးကို congratulations လုပ်ပါတယ်เนาะအားလုံး congratulations လုပ်ပါတယ် one paper on hematology and one paper on chemical pathology and 4 papers on the histopathology and immunohistochemistry ဒီ hematology paper မှာ hemoglobin A1C တိုင်းထားတာတွေ့တယ်ပေါ့နော်ဆရာလည်းအများအား hemoglobin A1C တိုင်းနဲ့ paper တိုင်းကိုနည်းနည်းထုတ်ပြီးပြောလို့ရှိပါတယ်အဲ့ဒါဘာလဲဆိုတော့ hemoglobin A1C results may be falsely low in the hemolytic anemias particularly in our country the congenital hemolytic anemias like the thalassemia and hemoglobinopathies at least though A1C တိုင်းတဲ့လူတွေကအဲ့ဒီ abnormal hemoglobin ကို exclude လုပ်တဲ့တယ်အထူးသဖြင့်ဗမာပြည်မှာ hemoglobin E ပေါ့နော်ကျန်တဲ့ S တို့ C တို့ဆိုတာမဖြစ်လို့ထားတော့ပေါ့ hemoglobin E ဟာအများကြီး common ဖြစ်နေတယ်ဟလာ E မှာ homozygote လည်းရှိတယ် heterozygote တွေလည်းရှိတယ်တော်တော်များများရှိတယ် at least 25% ပေါ့ဥပမာဒီမှာ sample 100လုပ်တယ်ဆိုလို့ရှိရင်20အစိတ်က hemoglobin E carrier တွေဆိုတော့ဒီမှာအခု46လား50လားလောက်ထားတယ်ဆိုရင်ဆရာကအတန်းပြီးတော့တွက်လိုက်တယ် hemoglobin E ဟာသူ့ထဲမှာ15ယောက်10ယောက်15ယောက်တည်းမနေဘူးပါလိမ့်မယ်ဘယ်ထဲတွေပါမယ်တော့မသိဘူးဘယ်သူတွေပါမယ်တော့ပြန်ပြီး data analyze လုပ်မှာက hemoglobin A1C level တိုင်းတာဖြစ်တဲ့အတွက်နော် hemoglobin A1C level ကိုဟိုတိုင်းတဲ့ study တိုင်းမှာဒီကလေးစားတယ်မဟုတ်ဘူးဘယ် study မဆိုအဲ့ဒီ check လေးကိုသတိထားကြပါ hemoglobin E ကို exclude လုပ်ပါ then အဖြစ်တော့နေတယ်ဒါပေမဲ့ဒါလည်းပဲ low abnormally low result falsely low result ရတဲ့ thalassemia တွေ alpha thalassemia ou beta thalassemia ဆို alpha thalassemia ou beta thalassemia နှစ်ခုပေါင်းလိုက်ရင်လေမြန်မာရဲ့ general population ထဲမှာသူကအသက်ကြီးကြီးငယ်ငယ် hemoglobin E လို့ပဲသူက 15% လောက်ရှိတယ် 15% လောက်ရှိတယ်ဆိုတော့ hemoglobin E ရော thalassemia နှစ်ခုပေါင်းလိုက်ရင် 40% လောက်က they may be the carriers or traits of the thalassemia and hemoglobinopathies အဲ့ဒါ hemoglobin တိုင်းနဲ့ hemoglobin A1C တိုင်းနဲ့ study တိုင်းအဲ့ဒါလေးသတိထားပေးပါနော်နောက်တစ်ခုကတော့ဒီ campus ပဲဖြစ်ဖြစ်ဒီ hematology ပဲဖြစ်ဖြစ်ပေါ့နော်ဘာဖြစ်ဖြစ် cut off တစ်ခုကိုရှာဖို့ကြိုးစားကြတာပေါ့ cut off တစ်ခုကိုရှာဖို့ကြိုးစားကြတယ်ဆိုရင်မိမိတွေးရှိတဲ့ cut off ကိုရဲဝံ့မဲ့တင်ပြပါရဲဝံ့မဲ့တင်ပြပြီးတော့ conclusion ကိုဆွဲလို့ရပါတယ်ရှိရင်လည်းမရှိဘူးရှိတယ်ပေါ့ဒါပေမဲ့လည်းဒီလို cut off ကိုဆွဲနိုင်ဖို့အတွက်တော့ go study မှာဟလာ sample မလုံလောက်တာကိုပဲအကြောင်းမပြပါနဲ့ sample ကိုမလုံလောက်လည်းပဲဒီဟာနဲ့အမျိုးမျိုး statistically ဒါဆွဲပြီးတော့ကို inference ဆွဲလို့ရတယ်ဒီအပေါ်မှာဒီ cut off ဆိုလို့ရှိရင်တော့ဒီလိုရှိပါတယ်အဲ့ဆိုတဲ့ဟာကိုဆရာကတော့အဲ့လိုမျိုးဖြစ်စီခြင်းတယ်လေဘာလို့ကိုလှုပ်ထားတဲ့ဟောပေါ်မှာဒါမှလည်းပဲဒီလိုပြောနိုင်မှုအတွက်ကတော့ကိုလှုပ်တဲ့ test တွေဒီတကယ်ကိုပဲ quality assurance အတွက်သေချာအောင်လှုပ်ထားတဲ့ test တွေဖြစ်တဲ့အတွက်ထွက်လာတဲ့အဖြေတွေဟာ true positive တွေ true negative တွေပါဆိုတာကိုပြောလို့ရတယ်ပြောလို့ရတာဖြစ်တဲ့အတွက်အဲ့ဒီအပေါ်မှာပဲကိုက inference ဆွဲရမယ် sample size နည်းလို့ inference မဆွဲဘူးဘာညာဆိုတာတော့မဖြစ်သင့်ဘူး sample size ကိုလည်းပဲနည်းတယ်ထင်ရင်စရတဲ့အတိုင်းဒီလူယူတဲ့ကို sample size ကိုတွက်ခဲ့တော့က reference ကိုယူခဲ့တော့ကလူရဲ့ sample size ကဘယ်လောက်မလို့လဲအဲ့ဒီဟာနဲ့ဆိုလို့ရှိရင် statistically ကိုကပြောချင်ရင်ပြောနိုင်အောင်sample size ကိုစရတဲ့အတိုင်းပဲတွက်ခဲ့ပေါ့နော်တကယ်လို့အဲ့လိုတွက်လို့မရဘူးအဲ့ဒီ sample size နဲ့ဆိုရင်ဒီ study ကလုံးလို့မရတော့ဘူးဆိုရင်လည်းပဲအဲ့ဒါတော့လုံးလို့မရဘူး sample size ဆိုနေတယ်ဒါပေမဲ့ဒီတွေးရှိချက်ကရရှိလာတဲ့ results တွေက true positive တွေ true negative တွေပါဆိုတဲ့ဟာကိုကအဲ့လိုမျိုး assume လုပ်နိုင်အောင်ယူဆလို့ရအောင် so we have to observe all the pre-analytical analytical and post-analytical laboratory errors တွေကိုကသတိထားရမယ် quality indicators တွေကိုသတိမူရမယ်ပေါ့နော်ဒီလိုပါပဲနောက်တစ်ခုကလည်းပဲ IAC ခု၄ယောက်လောက်ထားတယ်ပေါ့နော်ဆိုတော့ဟိုလည်းပြောသွားတယ်၄ယောက်လောက်ထားတယ်ဆိုကိုထွက်လာတဲ့အဖြေတွေအလုံးကို compile လုပ်ပြီးတော့ clinicians တွေကို clinical ကိုအထောက်အကူပြုနိုင်တဲ့ဘာပေါ့ clinical ကို information ပေးနိုင်တဲ့အဖြေလေးတစ်ခုဟိုကဆွဲနိုင်အောင်လုပ်ကြရမယ် မှာကိုတွေ့ထားတယ်ဒါကတော့ histological types နဲ့ဘယ်လိုတွေ့တယ် histological grades နဲ့ဘယ်လိုတွေ့တယ်ဆိုတဲ့အားတွေအားလုံးကိုဒီ types နဲ့ဒီ grades ဆိုလို့ရှိရင်တော့ဒီလိုဖြစ်လိမ့်မယ်လို့ positive predictive value ပဲဖြစ်ဖြစ် negative predictive value ပဲဖြစ်ဖြစ်အဲ့လိုမျိုးပြောလို့ရနိုင်တယ်မရနိုင်ဘူးအမှန်ကတော့ရကိုရရမယ်ကိုလှုပ်ထားတဲ့ sample ပေါ်မှာပဲကိုကဒီ sample size ကိုလည်းပဲဒီပြင် literature တစ်ခုကနေယူပြီးတော့ဒါတွက်ထားတာတွက်ထားပြီးယူထားတာဖြစ်တယ်လှုပ်တဲ့ method ကလည်းပဲကိုလိုပဲ standardize ဖြစ်အောင်လှုပ်ထားတယ်ဆိုလို့ရှိရင်ကို့အဖြေတွေအလုံးဒီpredictive value တစ်ခုထွက်အောင်ကိုကလှုပ်ဖို့ကြိုးစားတာဖြစ်တယ် objective ထဲမှာဟာ types နဲ့ပဲလို့ရှိပါတယ် grade နဲ့ပဲလို့ဖြစ်ပါတယ်အဲ့လိုပြောပြီးတော့ဒီလိုရှိလဲ predictive value မရပါဘူးမရရင်လည်းမရတဲ့အကြောင်းပေါ့ရဲဝင်မယ်ပြောဖို့လိုပါတယ်ကို study မှာဘာမှဟိုသူများနဲ့မတူလို့ဘာလို့ဒါ discussion မှာတော့ပြောပြီးပြီဒါပေမဲ့နောက်ဆုံးပိတ် conclusion မှာတော့ဘာလို့ဖြစ်ပြောပြီးပါပြောနိုင်အောင်လည်းပဲပထမ study တွေလုပ်ရတဲ့အဲ့ဒီဟာကိုရည်ရွယ်ချက်ထားပါ clinician ကိုဒီ test လုပ်လိုက်ဆိုရင်ဒီ information ပေးမယ်ဒါကို predict လုပ်လို့ရတယ်ဒါကိုခန့်မှန်းလို့ရတယ်ဆိုတော့ negative predictive value ပဲဖြစ်ဖြစ် positive predictive value ပဲဖြစ်ဖြစ်ကိုရအောင်ဒီ study လေးတွေစူးစမ်းပြီးတော့လုပ်ကြပါ research လေးတွေကိုလုပ်ကြပါနော်ဘာဖြစ်ဖြစ်အားလုံးကို congratulation လုပ်ပါတယ်ဆရာတို့ရဲ့အချိန်ကလည်းပဲသတ်မှတ်ထားတဲ့အချိန်ကတော့7နာရီဆိုရင်သူများ session ကိုပေးရတော့မှာဖြစ်ပါတယ်နော် so အားလုံး congratulation လုပ်ပါတယ်အားလုံးကိုလည်းပဲနေ့တစ်မှာကျမ်းမာပျော်ရွှင်ကြပါစေလို့လည်းဆုတောင်းပေးပါတယ် and ဘာဖြစ်ဖြစ်မကြမီမှာလည်းပြန်တွေ့ကြအောင်ပါအဲ့ဒါဆရာကတော့ဝဲရပဲနေလဲ28ရက်
နောက်ပါတင်နေ
အားလုံး congratulate လုပ်ပါတယ်
မတို့ chat ဖိတ်ခေါ်လာတယ်ကျေးဇူးတင်ပါတယ်
ငယ်တွေကိုအားကိုးရတော့မှာ
ကျေးဇူးတင်ပါတယ်ရှင်
အားလုံး
ဟုတ်ကဲ့ပါ
တင်ပါတယ်ဆရာယူလို့ရောမမအေးရောမမမြင်မွန်ရောဘယ်ရောက်သွားပြီလဲမမမြင်မွန်ဆောင်းရတွေ့လိုက်
မမြင်မွန်ထွက်သွားပြီ
နော်စုဇန္နာကိုလေးဓာတ်ပုံလေးတင်စမ်းဆွေစင်မြင့်ရောရှိလားငါတို့ဓာတ်ပုံရိုက်ပဲ
ဓာတ်ပုံရိုက်မယ်ငါမဆက်စီနေအောင်
ပါပြီလေဟဲ့ဓာတ်ပုံတင်သူတို့ကကြည့်ကဲငါတို့နောက်ဆုံးပုံ
ဖြတ်ပြီသူ
ချစ်စုလို့ဆွေစင်မြင့်လို့ဆွေစင်မြင့်အိမ်နေပကြားမကြီးနဲ့
ပြောနေတော့ငါဓာတ်ပုံရိုက်နေပြီ
ဟုတ်ကဲ့မမ
ဟုတ်ကဲ့နောက်ဆုံးဓာတ်ပုံ